what other new drugs are out there? Let's stay away from CAR T for a minute, but
Yeah. I mean, so the other one is Selinexor. And Selinexor is a selective inhibitor of nuclear export, or a SINE drug. And what it does is it turns off the chaperoning of proteins from the nucleus to the cytoplasm. And so some of the tumor suppressor proteins are better if they're in the nucleus, so cancer cells want to get them out of the nucleus. If you block that, actually the cells actually undergo apoptosis or are more normal. And so this is a first-in-class drug. It actually may, in fact, get FDA approved sometime in the next 2 or 3 months. So and they did this really interesting study, the STORMS study, where they took quadruple refractory or even pentarefractory, so refractory to lenalidomide, bortezomib, carfilzomib, pomalidomide, and daratumumab. And with Selinexor plus dexamethasone, the Selinexor is given twice weekly at 80 milligrams with dexamethasone. The response rate was, reasonable, 20 to 21%, and when a secondary party looked at it, they even got to 25% response rate. So that's really good in this very refractory population. The problem is there are side effects. You have to watch them fairly closely. And there's GI side effects, nausea, diarrhea. There's low blood counts that you have to watch. There's a little hyponatremia, and there's some fatigue. And so, I think with this drug, it's going to be one of those ones we got to watch patients really closely, and you have to give them supportive care as needed. But I think it will find a little niche in these refractory patients to all these drugs.
thoughts from this end of the table? Faith, Selinexor?
Yeah, so I agree. I think it's the patients that you have to take your hat off to them for designing the study. The patients that went into the study were really hard patients to treat. But as you say, I think it's managing those side effects in a very sick patient population that's going to be interesting.
There's some interesting data that would suggest if that mechanism of action works in myeloma, it could work on many other tumors. So from what I understand, without having direct experience in this, they've gone to the weekly schedule in lymphoma at the lower dose with, reported from what I hear from the lymphoma guys, better tolerability. I think if that drug could be made tolerable, then it could be, again, just like we're saying, venetoclax could be a sensitizer or an adjunct. You could imagine something, again, that increases MRD up front would be good.
And it has been combined with pomalidomide, carfilzomib, daratumumab, all showing better response rates than it as a single agent with dexamethasone or a doublet.
Right. And I am curious to see if when it's a little bit, patients who haven't been so far treated, it may become more tolerable. Because part of it, I think, is these patients have been beat up quite a bit by the time they get to pentarefractory.
My understanding is that the dex really helps with some of the side effects.
Yeah, I think for the audience, if it does become more widely available, it is important to recognize that very aggressive supportive care is required to get patients through this with antiemetics, and we've seen all kinds of other solutions, salt tablets, and keeping them well hydrated. There's a lot of challenges, I think, but it does perhaps have a role moving forward.